Hello. In this PowerPoint, we will review the most commonly employed non-invasive physiologic monitoring devices in the care of patients who suffer from severe traumatic brain injury. Over the past years, cerebral ultrasonography use has become more popular in the neurocritical care field. It is a non-invasive and easy-to-perform method to assess cerebral blood flow and tissue parenchyma. However, even though it's blossomed over the years, it should not replace the current standard of care, including non-invasive neuromonitoring and diagnostic imaging tools such as CT scan and MRI. Cerebral ultrasonography is most commonly used to assess intracranial hematomas and acute ischemic stroke, hydrocephalus, midline shift, and optic nerve sheath diameter measurement. Ultrasound has been used to accurately distinguish between intracranial hematomas and ischemic strokes. Intracranial hematomas are seen as hyperechogenic images, where areas ischemic tissue is hypoechogenic. When compared against CT scans, BMO transcranial color-coded duplex sonography proved to be able to correctly identify intracranial bleeds and ischemic strokes with a high sensitivity and specificity. Limitations of cerebral ultrasonography include the lack of visualization in the presence of a poor acoustic window, and the inability to detect small intracranial hemorrhages. Cerebral ultrasonography has also been used in the detection of hydrocephalus. In normal conditions on ultrasound, cerebral spinal fluid is anechoic, where areas that ependymal cells lining the ventricular system are hyperechogenic. When evaluating hydrocephalus on ultrasound, structures in the ventricular system that have shown the best correlation with CT scan measurements include the width of the third ventricle, the right and left frontal horns, and the middle part of the lateral ventricles. The lateral ventricles appear as a double railroad hyperechogenic lines containing CSF. During a patient's external ventricular drain clamping trial, the ventricular size increments of greater than 5.5 millimeters have been correlated with a failed clamp trial and the need to reopen the ventricular drain. Transcranial Doppler is also useful to identify the position of the EVD tip within the ventricular system and to detect catheter displacement. Midline shift can be calculated by measuring the distance between the skull and the third ventricle bilaterally. It is estimated as a difference between the IPSI and the contralateral measurements divided by 2. Although most studies assessing midline shift via ultrasound have been performed in stroke and supratentorial hemorrhage, there's been good correlation that has been reported in TBI subjects when measurements are calculated at the level of the third ventricle or the septum pellucidum. Under normal circumstances, cerebral spinal fluid flows in the optic nerve sheath from the posterior to the anterior segment. When an elevation of intracranial pressure occurs, cerebral spinal fluid tends to accumulate in the anterior segment of the optic nerve sheath, leading to elevated pressure within the optic nerve and changes in the optic nerve sheath diameter. These changes rapidly are followed by an increase in intracranial pressure. Ways of evaluating increased intracranial pressure are by measuring the optic nerve sheath diameter by placing a high-resolution linear ultrasound transducer probe over the closed eyelid. The optic nerve sheath is seen as a hypodense area behind the globe of the eye. The optic nerve sheath diameter is measured at a depth of 3 millimeters from the posterior pole of the eyeball, as this is the point that is most reflective of changes in ICP. The normal cutoff for optic nerve sheath diameter remains a debate, but most authors agree that less than 5 millimeters is a normal value. Optic nerve sheath diameter measurement is contraindicated in patients with common clinical conditions such as tumors of the orbit, ocular sarcoidosis, Graves' disease, and inflammatory eye disease. However, overall, while it has been established that optic nerve sheath diameter measurement may reflect elevations in ICP, its variable sensitivity and specificity precludes its utility as a diagnostic tool to replace invasive ICP monitors. In summary, although available ultrasound-based techniques have several limitations and should not substitute current standard invasive methods, they may help providers to estimate and potentially treat intracranial hypertension after a traumatic brain injury. Historically, pupil size and reactivity assessment have been a cornerstone in the neurologic monitoring in patients with traumatic brain injury. However, their assessment is subject to significant inter-observer variability since the measurement is performed subjectively using visual estimation, which decreases its reliability and validity as a diagnostic tool. A new objective and reproducible tool for pupillary assessment is the optical pupillometer. This device measures different parameters of the pupillary light reflex to create an algorithm reported as the neurologic pupillary index, also known as the NPI. Scores are reported on a scale from 0 to 5, with lower values representing abnormal pupillary response and values between 3.0 and 5 indicating normal to brisk response. Among the advantages of the pupillometer are the ability to detect subtle pupillary changes otherwise not perceived by the naked eye, minimal inter-observer variability, and possible lack of vulnerability to ambient light. Intracranial hypertension is a well-known cause of secondary brain injury, and its association with worsened long-term outcomes has been extensively studied. Consequently, monitoring of intracranial pressure is central in the management of TBI patients. According to the most recent Brain Trauma Foundation guidelines, ICP monitoring is recommended to reduce in-hospital and 2-week post-injury mortality. ICP should be monitored in all salvageable patients with a TBI, typically GCS of a score of 3 to 8 after resuscitation, and an abnormal CT scan that usually reveals hematomas, contusions, edema, or herniation, etc. The current gold standard for ICP measurement is the utilization of invasive devices such as the external ventricular catheter and intraparenchymal monitors. However, these techniques certainly can carry disadvantages, such as the risk for bleeding, intraparenchymal hematoma, infection, malposition, etc. Although non-invasive ICP monitoring devices are not fully recognized as providing an accurate ICP estimation, these monitors may be helpful when invasive methods are not immediately available or are contraindicated, such as in patients with coagulopathy. Among others, non-invasive ICP measurement tools include imaging, for example, CT and MRI, or optic nerve sheath diameter, pupillometry, tympanic membrane displacement, arterial transcranial Doppler ultrasonography, and neurophysiologic recording of functional activity such as EEG. During the next section, we will briefly explore some of the most commonly available non-invasive ICP monitoring techniques. Cerebral infrared spectroscopy, also known as NIRS, has been proposed as a viable, non-invasive method to assess for the presence of intracranial hematomas and an alternative to invasive brain oximetry monitoring procedures. The non-invasive nature of the device and its portability make NIRS a considerable tool for evaluation of the brain-injured patient. Oxyhemoglobin and deoxyhemoglobin are the most commonly measured chromophores. From the sum of their changes, total hemoglobin can be estimated. Additionally, regional cerebral oxygen saturation, tissue oxygenation index, and cerebral oxygen tissue saturation are defined as the ratio of oxygenated hemoglobin to total hemoglobin and expressed as percentages. These indices reflect local tissue oxygen consumption in areas of interest. When evaluating cerebral perfusion, the INVO system provides a regional cerebral oxygenation saturation, which is an index value that provides real-time changes of regional oxygen saturation of blood in the brain and cerebral perfusion. This system is a non-invasive cerebral oximeter that has been shown to correlate with jugular venous bulb saturation, which is the standard for assessing global cerebral saturation. Now, the NeuroSystem is a tissue oxygenation monitor that is also non-invasive, and it uses near-infrared spectroscopy. The unit uses a low light to measure the tissue oxygenation index, which measures concentration changes in oxygenated, deoxygenated, and total hemoglobin. According to Al-Rawi and colleagues, tissue oxygenation index reflects cerebral oxygenation at a high degree of sensitivity and specificity during carotid surgery. Nonetheless, there are no data available to correlate tissue oxygenation index changes with absolute measures of cerebral blood flow or cerebral oxygenation. Both systems rely spatially resolved spectroscopy to determine oxygenation values. Bone is considered to be transparent to the near infrared light, where areas skin and underlying tissue may contaminate the measured values. In order to minimize extracranial tissue contamination and measure true cerebral oxygenation, spatial resolution is utilized. Spatial resolution is a process in which oxygenation is measured by two detectors placed at separate locations on the subject's head, and the subsequent processing of data is combined to result in the theoretically true value of intracranial oxygenation. Measurements are significantly affected by skull thickness. For instance, NIRS has been observed to be more effective in pediatric patients given the thickness of their skull and scalp. Also, measurements of regional cerebral oxygen saturation in the forehead are significantly lower when measured in the upright position than when measured in the supine position. Currently, there's limited evidence to support the use of NIRS to predict outcomes post-injury. However, NIRS technology has been widely studied in the detection of intracranial hematomas, leading to consider NIRS technology as a screening tool for the presence of these lesions. The foundation for using NIRS to measure cerebral autoregulation lies in the assumption that brain tissue oxygen concentration positively correlates with arterial oxygen concentration, cerebral blood flow, and tissue oxygenation. NIRS output parameters utilized to assess cerebral tissue oxygenation are regional cerebral oxygen saturation, tissue oxygenation index, and cerebral oxygen tissue saturation. Researchers have proven a relationship between ICP and variation in NIRS indices, giving NIRS the potential to be used as a surrogate for invasive ICP monitoring. NIRS has shown good positive correlation when compared with some currently available cerebral oxygen monitoring and cerebral autoregulation technology. Further clinical research is warranted in this area of non-invasive tissue oxygenation monitoring. Finally, transcranial Doppler is an ultrasound modality useful in the assessment of the acutely ill patient. Among others, it is used for evaluation of subarachnoid hemorrhage, cerebral autoregulation, and to monitor hemodynamics. The main parameters measured are velocity and pulsatility of intracranial arterial blood flow. It was our pleasure to bring together this chapter for the internationally recognized Human's Textbook of Neurosurgery. We truly hope that you will enjoy reading the full chapter entitled Non-Invasive Physiologic Monitoring in Traumatic Brain Injury.